Okay. So,
Wow.
you want to start, Lola, and then I can open this.
Sure.
Great.
Hi, welcome everybody.
Sorry, go on.
Yeah, go ahead, Lola.
Okay. Thank you so much for joining. This is Lola, the coordinator of the Harvard and Beth Israel Deaconess Medical Center site for the New England Mental Health Technology Transfer Center, and this is co-hosted with MapNet as well. Please feel free to introduce yourself in the chat box. Now, I just want to review a couple housekeeping items before we begin. So participant microphones have been muted at entry, and you'll be able to unmute them during the discussion portion. During the presentation, if you have questions or technical difficulties please use the chat box. This session is being recorded and will be available for viewing at a later time on the MHTTC and MapNet websites. To reach us after the webinar, you can email newengland@mhttcnetwork.org. Next slide, please. These are just some acknowledgements for MHTTC. Next slide. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and lastly, consistent with our actions, policies, and products. So with that, I'll hand it over to Kelsey for introductions.
Yeah, absolutely. Thank you, Lola. And thank you for people introducing yourselves in the chat. Really glad to have you on here. So we're co-hosting also from the side of MapNet. So we're the Massachusetts Psychosis Network for Early Treatment here in Massachusetts. So excited to really bring some spotlight to this topic today and to have Kesh, Nina, Charles, and Nate all joining us. So I'll give a quick introduction to them and then turn it over to Kesh to start us off. Firstly, Dr. Mancheri Keshavan is the Stanley Cobb Professor and Academic Head of the Harvard Department of Psychiatry here at Beth Israel Deaconess Medical Center. So he's also the director of MapNet with us and has conducted early psychosis intervention and research for many years, almost 3 decades, has a prolific body of work to pull from. And then also Dr. Nina Schooler is the professor of psychiatry and behavioral sciences at the State University of New York Downstate Health Sciences Center in New York, New York. So she's been the president of the American Psychopathological Association, the Association for Clinical Psychosocial Research, and an elected counselor of the CANP and a member of the CSC Board of Directors. So is also coming to us with a really rich history and background in doing this kind of work. And then Charles Strohmeyer and Nate Schwerian are both members of our Consumer Advisory Board, or CAB, here at the Psychosis Research Program at Beth Israel. So Charles works in stock investing, advising startup companies, and doing research in artificial intelligence. And his hobbies include music, movies, neurobiology, and he especially enjoys mentoring young people, including 14 individuals in the Forbes 30 Under 30 list. And then lastly, we have Nate, who is an interdisciplinary Bachelor of Arts degree from UMass Amherst, and also an Associate of Science degree in biotechnology from Mass Bay Community College. So he currently works with Tunefoolery Music, which is a group of musicians in mental health recovery, where he works as an audio technician, a performer, and a meditation group facilitator. So really glad to have this array of experience here to talk about this. And with Kesh, I will turn it back over to you.
Okay. Thank you, Kelsey, and good morning, everyone. Hope everyone is doing well. It's indeed my honor to be working with all the 3 of the individuals who are participating in this webinar with me. Nina Schooler, who was one of my early mentors many years ago at the University of Pittsburgh, and then Nate and Charles, with whom I have the privilege of working as part of the Consumer Advisory Board. So let me skip the same slides that you already saw. So the way we want to do this, we have about an hour and a half, And our goal is to get a kind of a multi-stakeholder perspective on the psychopharmacology of psychosis. So we want to begin, as we always should, with taking the perspective of the individual with the lived experience of the mental illness. And so we are privileged to have Nate and Charles here with us. And what I'm going to do is to pose them some questions and get each of their perspectives, which will kind of give us the basic understanding of what we should know about psychopharmacological treatment in individuals with psychosis. And then after that, I will provide a summary from the literature as well as from my own experience as to what is the state of the art of psychopharmacology in psychosis. And then we will have a discussion from the group, including questions and answers from those who are participating here. And please introduce yourselves as you speak. And following that, we will have Nina Schooler give us a big picture perspective. She's a leading psychopharmacologist that has kind of seen this field for the last several decades, and she will tell us where we are and where we are going and where we should be going, and so forth. So one thing I want to, Nina reminded me to say this, that a number of you are prescribers, but a number of you are not traditionally called prescribers. But then, for the purpose of this discussion, think of yourself like a prescriber. What would you have done in those kind of situations from your own perspectives and so on? So that will really lead us to a good understanding and perhaps a good discussion as well. So my first question here for Nate and Charles, either of you could jump in, so take a minute each, or minute and a half, to tell us what do you think is the most important for new providers to know about medication management in psychosis? So Nate or Charles, either of you.
Yeah, this is Charles.
Yep.
And for me, the most important thing to know is trial and error to get the right medications and dosages in order to prevent relapse, which I'll define as hospitalization.
Mm-hmm.
For me, that's most important, especially because I have to care for my elderly parents and I can't go to the hospital and risk getting COVID, for example.
Yeah.
And my prescriber thinks I trust him, and he works with a lot of young people, including people with substance-induced psychosis. And for him, the most important thing is getting them to take their medications as prescribed.
Mm-hmm.
And he's even contemplated paying young people or giving them the chance to win a reward if they take their medications. Two caveats with that are that where would the money come from? And a recent area of schizophrenia research is some people with schizophrenia have deficits in rewards processing. So I don't know if his idea would work, but for both him and me, that's the most important thing, is preventing relapse.
Oh, thank you so much, Charles. Those are very insightful points. And the one takeaway for me from that is the point that, it is such a wise point that a little bit of a trial and error is always needed to find the right treatment for the right individual. And this is partly because psychiatry, as we know, it is an imprecise science. We don't know upfront as to what might work or what might not work and so on. So a partnership has to happen between the individual patient and the prescriber to find the best treatment. So for that, therapeutic alliance is so important.
Right. I'll make if I could just add one more point to that, because I think it's a really critical one. And that is that the information that we have that makes it possible to have these medications available are based on averages. And so they're based on groups.
Yeah.
And when we look at the group averages, virtually many of the medications seem to be very, very similar, but that doesn't mean that they're similar for the individual. And it also, the fact that there needs to be trial and error doesn't mean that there's anything wrong or bad about the way doctors and nurse practitioners are prescribing medication. It's just that individuals are so different.
Yeah, thanks, Nina. That is a brilliant point. And in fact, we will come back to this when I do my presentation, that, science can give us at a broad group level as to what is the way to do things. But how we do it at an individual level is something that we learn as we go along.
Right.
Charles? I'm sorry, Nate?
Yeah. I think really important point is that treating someone with antipsychotic medication is a balance. So it's important to treat symptoms, but it's also important to try to minimize side effects.
Yeah.
So treatment with antipsychotic medication is, I'd say, a balance between symptom reduction and minimization of side effects. Antipsychotic dose should be enough to treat symptoms, but also low enough dose that to try to avoid a severe problem with side effects.
That's an extremely important point, Nate, that you bring up. So let me throw in my little acronym for how we choose medicines, and that incorporates that. Remember 4 E's. See, the choice of a treatment should depend on, first of all, efficacy. Does it work? Secondly, side effects. Thirdly, the ease of use. How easy is it to use versus a very complicated regime? And finally, economics. Is it affordable, and so on. So with that, let's go to the next question for both of you. Maybe Nate, you can jump in first. What
Okay.
have your previous prescribers done that did not work well for you?
Well, treatment that had the goal of decreasing symptoms by prescribing high doses of antipsychotics caused side effects that were difficult to tolerate. I think what works best is to prescribe the minimum effective dose of antipsychotics,
Mhm.
and then possibly add other treatments to treat the side effects. You can treat the side effects almost as if they're another disorder, like a depressive disorder or something like that. So antidepressants can help treat the side effects. And I'm a little bit unsure of this, but I've been lately having ECT to try to help deal with side effects, and it seems like it helps somewhat. So I think that's something that's possibly worth trying. But
Thank you. I think your point on the dosing is so critically important. Nina is here, and so maybe historically, I can say a little bit of an anecdote that she'll remember. When we started understanding and treating the first episode psychosis patients, the new drug came along, risperidone at that time, and the manufacturer recommendation was 6 milligrams a day. And we started that because we thought that that's the way wisdom from people who developed the medication would be, but we miserably failed because patients didn't like it at all. They were stiff as a board, and so we had to work it out and figure it out that the better way to do it is start slow and go starts low and go slow. So that's
right.
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 Remember that.
I just want to add something else about that experience, because although it was a very long time ago, I remember it very clearly. And what the issue was, I think, was the difference between treating people with a first episode of psychosis and people who've had long years of exposure to antipsychotic medications. And the studies, again, that the drug company had done to demonstrate the efficacy of the medication had been done in people who had long histories of drug exposure. And the people who were being treated with their first exposure to an antipsychotic, their bodies and brains had not had that exposure. And so, of course, the dosing was very, very different.
Thank you, Nina. In fact, this will resonate again when I do make the presentation. That is what the literature is telling us, that first episode patients do well with smaller doses. That's something that we did not very well know early on.
Right.
So,
right. But we've learned.
Yeah, exactly. Charles, you have anything on this point?
Yeah, what did not work well for my case was once a psychiatrist didn't spend enough time with me to get the diagnosis right. So I was first diagnosed with bipolar disorder, but I kept having unwanted and intrusive thoughts, even in the absence of mood changes. So later my diagnosis was changed to schizoaffective disorder. And then I enrolled in a study in MGH that enabled me to switch medications, and that worked really well. And I just add that a recent study from McLean looks at the diagnostic stability of psychosis and finds that switching from bipolar to schizoaffective is much more common than the reverse.
Yeah. Oh, thank you. That's so insightful, Charles. I often think the difference between a good psychiatrist and a bad psychiatrist is 45 minutes versus 15 minutes. You spend more time, you listen and learn better. And I'll come to that later again. So yeah, thank you. Let's go to the next question. What have your previous prescribers done that was helpful, Charles?
Optimizing my meds combination. So I take aripiprazole, which is an antipsychotic and mood stabilizer, in addition to venlafaxine, which boosts or helps prevent depression and anxiety, and in addition to armodafinil, which is an atypical psychostimulant. And the combination works super well for me. So not the trial and error of not just the right meds, but also the right dosages.
Yep.
And in addition to that, the timing of the meds with circadian rhythms, because I can't sleep well at night without an antipsychotic. So I take it before I go to bed.
Perfect. Yeah, thank you so much. So the point that you bring up illustrates the key thing that we think about, which is that polypharmacy is not necessarily bad. Polypharmacy, well done, when it is done intelligently, thinking about the different strengths of the different medicines and combined in such a way that the side effects don't get exaggerated, is the right way to do it. And often that the best combination is learned by the patient and the doctor working together. Thank you. Let's go to the next. Nate, do you have any comments on this?
Yeah. I'd say prescribers who tried to minimize the dose of antipsychotic medication so there'd be fewer side effects, and who also prescribed other medications to treat side effects have been helpful.
Right. Absolutely.
I had one hospitalization which was having trouble treating my symptoms, and in that hospitalization, they used ECT to reduce symptoms, and it did effectively treat my symptoms of psychosis. So ECT can be helpful for depression or psychosis. And at a later time, I was being treated as an outpatient, and when side effects were not treated effectively enough by medication, so still like having depressive side effects from the medication. ECT again, I think has been somewhat helpful, but it's not completely clear on that.
And what you say is it illustrates the point that each person might benefit from a different approach, and the treater and the patient work together to find what works best in a creative manner. It's a partnership, as we will talk about it as we go forward. ECT is highly stigmatized, and the fact that you point out its benefits is very, very important for everyone.
Yeah, I mean, when I a long while back, I had definitely a negative impression on ECT, but they use anticonvulsant meds so that the seizure that they're inducing is localized to the brain. So it's really actually seems, my experience of it is I get I forget what you call it, forgetting the word for it now, but you get the medication to anticonvulsants and something that knocks you out pretty much. And then it's the next thing I know after getting that medication is I'm waking up. So it's really, it's not a bad experience.
May I point out to this audience that you are just finishing or you're in the middle of an ECT course, right?
I am, yeah. I mean, I guess I'm getting to sort of probably towards the end of it. So I think the amount of treatments I'm having is
that's so important for people
decreasing.
to hear, because there is all this misconception in the
Right.
population that ECT is bad or ECT causes memory problems and things like that. The fact that you're here just a few days ago, you received an ECT and you're talking to a group like that, it's so much insight.
Right.
Yeah.
That's how helpful it is.
Nina. I mean, there might be some memory effects, but they're not too bad.
Yeah. It's great. Nina, you had something to say.
Yeah, I was going to say modern ECT, there's also been huge evolution in the way the treatment is administered because of increasing understanding about how it should be done and what the minimal, again, it's a dosing effect in many ways, minimal dose to get the proper effect rather than maximal dose.
Right, yeah.
And unfortunately, many people only know One Flew Over the Cuckoo's Nest.
That's right.
Yeah. That's actually a long while back, my father was going to have ECT.
Exactly.
And I was opposed to it. I was like, don't put him through that, because I had seen that movie One Flew Over the Cuckoo's Nest, and I was like, that's terrible. But it's not. It's a misconception, at least for modern. I mean, it really seems like they do the anesthesia, and the next thing I know, I'm waking up and like going to the recovery room. So it's actually not a bad experience.
Yeah, no, I think a part of the stigma for ECT is its name itself, convulsion, electroconvulsive, shock therapy, and so on. I've wondered whether, different names such as neuromodulations, it comes under neuromodulations. It might be a better way to name it. So we have to work towards reducing stigma in this. Thank you so much.
Yes, actually, can I ask, because this is something that is somewhat new to me, is this something that would be considered in a first episode timeframe, or at what point would something like ECT come into the conversation?
ECT is used if, irrespective of whether it's the first episode or a chronic illness, if there are certain features such as, say, catatonia or very severe depression along with psychosis, or even a first episode psychosis which is not responding well to standard treatments, ECT has a place, but it is not often brought in early on in illness. Yeah, good point. Fourth question, what are your thoughts about shared decision making? Charles, you can go on this.
Okay, so I take the maximum recommended dose of aripiprazole, which is 20 milligrams. So my prescriber and I once wondered if I could function well on a lower dose. So we went to the next lower dose, 15 milligrams. But I started feeling spacey and like a robot on the one hand and more depressed and anxious on the other, like positive and negative symptoms. So we went back up to 20 and then I felt fine again. So that's an example of shared decision-making where it worked out favorably.
Oh, thank you. I mean, I often think that we as trained prescribers might know what might work for, groups of individuals, but you, with those with the experience of illness, you know your illness better than us. So this is why we have to pull that information together in a shared decision model. Nate?
Well, I think it's important that medication should be a collaborative effort between prescriber and person being treated. A prescriber might think that high doses of antipsychotics, they might want to prescribe high doses to treat the psychosis, but antipsychotics can cause really difficult side effects. So it's good to not do that. I'd say prescribing lower doses of antipsychotic so that there will be fewer side effects might be a good basis for some medication. And then once the psychosis symptoms are treated, it's important to deal with side effects. So part of dealing with side effects could be getting the antipsychotic dose as low as it can go. So that's part of treating the side effects. And then other medications can be added to treat side effects as you would treat an illness like depression. For example, the person might need antipsychotic medication to treat their symptoms, but once they're taking the antipsychotics, they might need other medications such as antidepressants or benzodiazepines.
Yeah, thank you so much. As final question, is there anything else about your own recovery journey you would like to share in order to teach new providers about how to promote recovery? Charles, you want to go first?
Yeah, I have a very supportive family. So getting feedback from them and also working well with them helps. That's something prescribers should consider too.
Yeah, thank you. Nate?
Again, antipsychotic medication could cause severe side effects. If possible, if possible, it's a good idea to avoid using them, but that's sometimes not possible.
Yeah.
So if use of antipsychotic medication cannot be avoided, it might be good to prescribe the minimum effective dose of the antipsychotic medication, and then but prescribing even a minimal dose of antipsychotic can still cause difficult side effects. Antidepressants can be used to help treat side effects of antipsychotic treatment. And another potential treatment for side effects is ECT. That's could be possibly used for that. And possibly treat side effects almost as if they're another symptom of an illness.
Yeah.
Can use medications to try to treat those.
Yeah.
I just wanted to add one thing, and I wonder if either Nate or Charles would comment on this, and that is that prescribers really, there was some talk about, you talked about engaging families, but I think another group to engage are other members of the treatment team.
Yes.
Who can provide other aspects of treatment and services that can promote recovery. So medication alone I don't think makes a recovery journey. It takes an entire treatment team working along with the individual, with the illness, the prescriber, and all of the other kinds of services that are available. And that's especially important, I think, for first episode psychosis.
Yeah, thank you, Nina. You actually anticipated a number of things that I was going to say. It's so critically important. It's so critically important. This is why this whole concept of a coordinated specialty care program
Exactly,
evolved.
exactly.
A village. It takes a village to treat a complex illness like psychosis.
Absolutely.
We'll talk about that. Thank you.
Especially if recovery is your goal.
Exactly. And so all of you have made my next task quite easy. Even though I have about 30 slides, I can probably go through them quickly. And, in fact, each one of them will resonate with a number of points that you all have already made. So let me start off with a study that was done by Delbert Robinson, which looked at the frequency of problematic psychopharmacology in early psychosis programs and so forth. And what he found was that almost 40% had one or other problematic prescribing practice, often high doses, like what Nate pointed out, that is often used, especially this is a situation in inpatient settings where you really need to get the patient discharged soon. And so the escalation of dose that happens quite quickly. And then the outpatient clinicians are a little bit too hesitant to bring it back because 40 milligrams of olanzapine worked. Why should we meddle with it? So the patient is on 40 milligrams a year later, 2 years later. So it's a terrible idea. So the use of antidepressants without indication. So that's another often problematic practice. Multiple antipsychotics is another thing. Again, it often starts in the inpatient setting. When one doesn't work, within a week, you try the next one, but you don't take the first one away, and it keeps incrementally adding up. So that's another problem. And often psychotropic medications, but not an antipsychotic, can be ineffective and can be a problem. And high doses, again, as I talked about, and use of stimulants. Often patients come to us with ADHD diagnoses and are on stimulants and so forth. So those are some of the common problems. But let me start with a case to illustrate some of the principles that I'm going to talk about. And this will be interactive. And Kelsey, do you want to share it?
Sure, I can pull up the poll. Do you want to read through the description first, just in case the poll blocks it? Sure.
So this young woman, these are all patients from my own practice. They're slightly modified to take away any kind of identifiability. This woman with schizophrenia has been stable, symptom-free for over 6 months on risperidone 4 milligrams per day. So I see her on a routine med check for 15 minutes. She's beginning to hear voices over the last couple of months and is somewhat more paranoid towards her husband in the last couple of months. Her medications have not changed. She has been taking it regularly and she denied any recent stresses of any kind. So what would you do? So this is where the question comes. Yeah. Okay, 60% of you said increase the dose. It keeps changing a little bit.
Yeah, it looks like we're still getting some people in. We can give it another minute.
Okay, so this seems to have stabilized.
All right, so I'll launch that.
Okay, so 2/3 of you wanted to increase the dose, and 1/3 said refer her to a therapist for, family issues. So let me say what happened. So these are the 4 things. At the end of the med check, she asked me if she could just ask another quick question. The time was up, but then she wanted one more question. So I gave her time, and over the next 30 minutes that followed, she admitted to being a little bit worried about the diminished sexual desire. And upon further inquiry, she reported her periods being irregular and also having some bone pains. She had gone to her PCP, who had started her on some meds about 3 months ago. This much information I got. What do you think should be the next step?
Okay. Right. Oh, do you have another screen to share, Kelsey?
No, this does not have a, this is not, sir, there's not a survey.
Oh, okay.
So what you can do if you have an answer is just speak up. Not Nina.
Yeah, right. I
From
backed
the
out.
audience.
Right,
So,
right.
Could you consider a drug interaction with whatever meds the PCP prescribed? But I'm not a doctor.
absolutely, you got it. So what I did was I called the PCP. PCP pointed out to me, he didn't know that this patient was seeing a psychiatrist. And so he said that there was hyperprolactinemia, and unbeknownst to me, she had been started on a medicine for the hyperprolactinemia, bromocriptine, 2.5 milligrams a day, which is a dopamine agonist. What does dopamine agonist do? It basically neutralizes the effect of risperidone, right?
Right.
So she had a breakthrough psychosis because of that drug interaction with bromocriptine. So you would not know this unless you took that extra few minutes to talk to her and let her come out with her concerns. 15 minutes might check would not have done that. So that's the main point I want to make out of this.
The hyperprolactinemia might be due to the risperidone.
Oh, exactly.
Yeah, exactly.
Exactly right.
Yeah. So that's the story. And, it also makes the next point that I'm going to do, that is that even if I missed it, another team member would have picked it up anyway. So that's what brings us to this coordinated specialty care. So, so there are 10 C's that I would like to say that summarize, good psychopharmacology prescribing in practice. And these are, first of all, we need to develop an alliance with the patient, connecting and developing a partnership, a comprehensive assessment, a coordinated care, so let's see here. Correct choice of medicines, the right dose and duration, making sure that the patient is complying with the treatment. Compliance is not a good word. Adherence maybe, or alliance might be a better word. Collaborative decision-making, checking for comorbidity, checking for side effects. And if you really don't know what's going on, get a consultation, get a second opinion. So these are the 10 C's that I would say that are important to keep in mind. Now, coordinated specialty care. Psychopharmacology is one part of multi-elements of care. I often worry about that. In fact, I don't like the word prescriber because there's nothing like a real prescriber. All prescribers do more than prescribing, so to speak. A prescriber has to interact with several other aspects of what's happening with the patient. Is there a comorbidity with a substance abuse? Is there, how is the patient doing in terms of, functioning in day-to-day life? What's happening with regard to the family? What's happening with regard to the medical health aspects of things? So good care involves a coordination between psychopharmacology and all other aspects of care. So this is where the teamwork becomes so important. And even if you have seen the patient for only 15 minutes, if you can chat about the patient in a weekly team meeting and check with others, you will probably get what you might have missed. So that's very important. So that is the aspect of coordinated specialty care. The second important thing is developing an alliance with the patient. And so there is a very important principle for this. It's called the LEAP principle. trying to get the patient's perspective as much as possible. Listen, empathize, find a point of agreement, and develop a partnership. That's a ground principle for developing a good therapeutic alliance. There was a book written by Xavier Amador that I would recommend everybody, if you haven't read that already, called I'm Not Sick, I Don't Need Meds. And at the beginning of psychopharmacological treatment, we should always have a good psychoeducation session with the patient. It may be more than one session where we teach the patient about the nature of the illness, about the nature of the treatment. I often go to the blackboard and explain to them what does dopamine do and so forth. And often it helps to explain that dopamine, on the one hand, increases the signal in the brain, and thereby your concentration might get better. Your ability to think clearly gets better. At the same time, it reduces the noise in the brain, and thereby your hallucinations get better. The chatter in your mind gets better, and so on. Using models from medicine like blood pressure, asthma, and so forth are quite useful and can be destigmatizing. And the third important principle is, the comprehensive assessment. Diagnosis always should precede treatment. Get to know the patient well, not only in terms of the diagnosis, but also the antecedent medical or comorbid medical illnesses, attitudes towards medication, previous treatment response and side effects, previous treatment adherence, any over-the-counter or alternative medicines the patient is taking. All of those are very important, and quite often lab test results are needed as well, say like liver function, kidney function, prolactin levels, glucose, lipid profile, sometimes blood levels of medications, and so forth. Let's see here. Of course, as I said in my case, spend time with the patient and just get more information from the patient, and also review previous records and get previous charts and so on. There are several medications available. There is broadly the first generation antipsychotics like haloperidol and fluphenazine and thiotixine and so on. And then there are the second generation medicines like the also called atypicals, which include risperidone, aripiprazole, quetiapine, clozapine, ziprasidone, and so forth. The atypicals have an important advantage of not producing extrapyramidal side effects like Parkinson's like symptoms, akathisia, which is restlessness, dystonia, and so on. Whereas some of the atypical antipsychotics have a different kind of problem, which is they can cause weight gain, they can increase the risk of metabolic syndrome, and so on. So how does one go about choosing the right medicine in the right patient? So all medicines, with the exception of clozapine, work approximately similarly in their efficacy. They differ in side effects. So you would want to know what particular side effects do you want to avoid in this particular patient. If you particularly want to avoid, so let me see, this animation is not exactly working. Okay, so if you want to avoid extrapyramidal side effects like Parkinson's, avoid first-generation drugs like haloperidol, fluphenazine, and even risperidone in higher doses can cause extrapyramidal side effects. But consider some of the other atypicals like olanzapine, quetiapine, aripiprazole, ziprasidone, lurasidone, cariprazine, brexpiprazole, and so on. If you want to avoid weight gain, avoid olanzapine, quetiapine, risperidone, clozapine, but consider some of the more recent atypicals like Abilify, aripiprazole, ziprasidone, lurasidone, cariprazine, and so on. If you want to avoid sedation, let's say, a student who is about to take an exam or someone who drives for a living, avoid drugs like olanzapine, quetiapine, and clozapine, whereas some of the more alerting medications like lurasidone and cariprazine might be better. If you want something that works fast, there are injectables available, fast-acting injections for haloperidol, fluphenazine, risperidone, M-tabs, ziprasidone injections, acinapine, sublingual, and so on. If you are coming to the point of 2 or more medications not having worked, clozapine is the way to go. And if there are treatment adherence issues, long-acting injectables are available for both first-generation drugs like haloperidol and fluphenazine, but also for more recent drugs like risperidone, paliperidone, olanzapine, and aripiprazole. In RISE-ATP, it was recommended that chlorpromazine and haloperidol should be second-line agents due to side effects. And the first-line agents, the RAISE study suggested include drugs like aripiprazole, quetiapine, risperidone, ziprasidone, and so on. Choosing the right dose is critically important. As Nina pointed out earlier, first episode patients may respond well to even smaller doses, and their dose requirement may be about 50% of what is needed in chronic patients. The Preventing Morbidity study treated first episode patients with a monotherapy of either olanzapine or risperidone for about 4 months. So the point here is not to drop an antipsychotic just because it didn't work too soon. You have to give it some time. And the improvement accumulates over the course of time each week. And cumulative response rate is about 40% by week 8 and about 54% by week 12 and even more by week 16. So time helps. Treatment adherence and treatment continuation is critically important. Discontinuation is associated with a significantly increased relapse, and relapse is very bad because each relapse has its consequences on the brain itself. There's more brain tissue loss, there is more negative symptoms, there is more cognitive dysfunction, there is more incarceration, more functional disability, lost opportunities. So it's important to ensure maintenance antipsychotic treatment where you know that the patient has a primary psychotic disorder. Even though there is some controversy in the field that people who stop medications or are treated on very small doses may be doing better at the end of 7 years. But here's the issue of diagnostic heterogeneity. If there are people who are who don't have schizophrenia but may have an atypical psychosis or a psychotic disorder in relation to cannabis, and they don't need to be treated for many years at a stretch. One may consider short-term interventions in them. And there are many reasons for poor adherence, and they may be because patient refuses medicines, or because medicines are not working, or because of side effects, or because they just don't show up, or they frequently keep missing or forgetting treatment, or maybe because they don't believe that they need treatments. So the approach to treating poor treatment adherence depends on the cause of the treatment non-adherence. So depending on the cause, improving therapeutic alliance and dosage adjustment and considering clozapine for treatment resistance, considering medication side effect monitoring and addressing the side effects, improving hospital to clinic continuity and making care more accessible and patient-friendly, and also cues to remember, memory aids like pill boxes, alarm watches, phone call reminders, long-acting injectables, and so on are very important. Check and manage side effects. Nate really made this point very strongly. Prevent side effects by careful history and appropriate choice. Early monitoring and letting patients know that you might have this problem. Just call me right away if you have this. Especially when you're starting an antipsychotic for the first time, explaining to them about akathisia or dystonia is critically important. Start low. Low. Yes.
For lowering side effects, through my history, quetiapine has had kind of the lowest affinity for dopamine receptors.
Yeah.
So that can be a way to reduce side effects. Some people don't like to prescribe it because they feel like it might be too high of risk for symptoms coming back for relapse. But I think that quetiapine has had kind of the lower incidence of side effects.
Absolutely,
I mean,
especially extrapyramidal side effects. Quetiapine has a very low rate of akathisia or
Yeah.
dystonia, and it may be related to a unique mechanism of how quetiapine works. Unlike some of the other antipsychotics, its effects on the dopamine receptors are transient. It's like fast on and fast off. It goes and blocks the dopamine and gets away.
Yeah.
Yeah. And Nina may have more things to say on this.
A little later.
Yeah. Okay. All right. Thank you.
I'll let you go ahead at this point.
Yeah. Okay. Let's go to our second case. This young lady has been stable, till about 3 months ago when she was briefly hospitalized, and she previously was on clozapine, amitriptyline, and lithium. And then at the hospitalization, she was added additionally perfenazine, which is trilofone, and benztropine, which is cogentin, and clonazepam during the hospitalization. So after discharge, she's in a partial hospital. She's supposed to come 3 days a week, but she didn't show up for her appointment. By the time the afternoon, the neighbors got concerned because children were crying loudly inside, and Mary was not answering the door. What might account for her situation? Yeah. So pretty much all of you, majority of you came up with drug interactions. And so let me ask the question, what particular aspect of these medications might be causing this problem in particular? You guys can speak up, put something in the chat. What is it that is common to a lot of these medicines? When I say that, amitriptyline and clozapine and benztropine and perfenazine, what is common?
I would say that they're kind of unpredictable.
They are unpredictable, but there is some level of predictability because they all share one common thing, one common property.
I would say the anticholinergic side
Absolutely.
effect from cogentin and the amitriptyline
You got it.
combined
Yes.
can cause memory issue and
So the police,
cognitive impairment.
yeah, you got it. The police were called in and they entered the house to find that Mary had been deep asleep. When she woke up, she admitted to having been very groggy and said that she may have taken the morning medicines again because she forgot. So when you said anticholinergic, this is exactly the issue. Her memory was wiped out. And anticholinergics are the best way to remove memory or, really decimate someone's memory, especially at this kind of dose. And so poor lady, she, honestly got up and very compliantly took her medicines, went back to sleep because of the histamine effects of clozapine and the anticholinergics, the sedating effect. Got up again, had no idea that she had already taken the medicine. She overdosed herself, in essence. This is what happened. So this is just an illustration of the fact that too complicated a regime and using too many medicines in combination without worrying about or monitoring side effects can be a problem. Let's go to the next one, which is the important issue of collaborative decision-making. This was already discussed a little bit when we talked about in the discussion. With
Oh, shit.
Kesh, I think we lost you a little bit there.
I can't hear. Do you?
Right, yeah, I can do that.
Okay, yeah, it looks like he had to drop out and come back.
Oh, dear. So maybe while we're waiting for Kesh to return, I'll make a brief comment about the last case. I think what that demonstrated, all the things that Kesh spoke about were obviously true, but what it also demonstrated was the fact that what happens often during hospitalization has a kind of disconnect with what's happening to the person in their long-term real life treatment, because the goal in hospitalization, for all the obvious reasons, is to get somebody better as quickly as possible and discharge them. And so you see the addition of other medications without taking away anything that had been there before. And so you see here was someone who went in, I think I counted, because that's something I always do. I think she went in with 3 drugs that she was required to, 3 medicines that she was required to take, and came out with, I think, 7. And that's a challenge in anybody's life, at any rate. So.
And is there anything you would think would be helpful, especially maybe for somebody who's in a first episode program, goes into the hospital? How would you go about coordinating that to make sure, you know, that does not happen?
Yeah, well, that's actually, that's in many ways among the most challenging things that we face, because the CSC program like MapNet and the programs that I've been involved with, like the RAISE ETP study, and now the NIMH EpiNet coordinated specialty care programs, place an emphasis on continuity and the importance of treatment teams. And part of the problem becomes is that usually the hospitalization is not directly coordinated with that. And the most important thing is to make sure that when the person comes out, there is that coordination, and having someone perhaps on the team who's designated to do that, so that the subsequent team meeting can be used as an opportunity to share that information and make sure that the person gets back on track in the coordinated specialty care program. But it can be a challenge.
Yeah, my apologies. Somehow I got thrown out of the internet. And so let me see if I can share it back again. Can people see my slide again?
Yes.
Yep.
Yeah.
Yeah, and we lost you right at the top of the slide following that case study.
Okay, so this is where we were, I think, right?
Before that,
Before that. Okay, let's
I think maybe 1 or 2 back. That one.
Right there.
Oh, this is where you lost me?
Yep.
Oh, okay. All right. I'm so sorry. Yeah, so basically we discussed the collaborative decision making when both Nate and Klaus answer those questions, and you already know the concept. So let me illustrate that by a case. There is evidence that shared decision making improves outcomes, not only patient satisfaction and treatment adherence, but also quality of decision making. So this young lady, as an example, is under treatment for schizophrenia. She has had, again, there's a little bit of a,
Oh, I think we need to go, there we go.
yeah. So she is treated. What's happening here is that the my slide is being blocked by the pictures on the screen. Let's see. Okay, so you can read it. So over the last year, her delusions and hallucinations have responded well to clozapine, but she's troubled by excessive sedation. Now she wants to discontinue her clozapine because she's afraid she may lose custody of her children. So this is where, Kelsey, you would share, yeah. I'm not seeing any answers coming yet.
Here, I can close the poll in a second and I'll share those here.
Oh, okay, great. Yeah. So,
There you
you know,
go.
the majority of you answered the key point of, collaborative decision making. What we did here was we told her, Jane, you could consider addressing the sedation problem with a medicine I'm going to prescribe you, namely modafinil, and so thereby we can make it some adjustment of the dose of clozapine, but it would help if you kept the clozapine on, but work on the side effect problem. So that's how we were able to get her to stay on the clozapine, because the risks of both continuing clozapine, in which case she would have stopped it herself anyway, or discontinuing clozapine, which would have led to almost certain relapse. You don't want to take that. And so work with the patient to find what might work best for you. Comorbidities are very common in psychotic disorders. As you see here, almost 50% of people with schizophrenia have either dyslipidemia, an increasing proportion as the illness continues, of smoking. And chronically ill people have about 70-80% likelihood of being smokers. And in the first episode, already about 40 to 50% are smokers. And smoking can interfere with treatment efficacy and may require larger doses and so on. So that's important to keep in mind. And substance abuse is also highly comorbid, frequent. In first episode patients, about 1/3 of them have one or other substance abuse disorder. These days, cannabis is very common. Smoking we talked about, and depression, other medical illnesses that are considerably comorbid. So in summary, the 10 C's are coordinated care, connecting and engagement, comprehensive assessment, and comprehensive treatment, including not only prescribing, but also psychotherapy and other aspects of treatment. The right choice of the medicine, the right dose and duration, treatment adherence, and making sure of collaborative decision-making, addressing comorbidity and addressing side effects, and consulting where necessary. So I think that's my last slide. I will stop sharing here. We have about 25 minutes for questions, and Nina's summary towards the end. So stop there. Thank you.
Sure. Well, I'll start with, we have a couple questions in the comments. So first, Kesh, we had followed up on your case presentation on Mary by talking about coordinating with prescribers after a hospitalization. So Ken Farbstein from one of our teams in Massachusetts is asking, who and how should we go about doing that right following a hospitalization?
So how we should coordinate care, is that what?
Right. So follow up when somebody is discharged, who should be the one making sure that we're avoiding things like high dosage polypharmacology?
Yeah, so typically it would be the prescriber who would work closely with the other team members to consider all aspects of care, including ongoing stresses and the treatment response, as well as families' input, as well as the input from the employment counselor, substance abuse counselor, and so on and so forth. So a team-based discussion is the best way to optimize treatment following discharge from a hospital. Maybe others have comments on from this group. Nina would have some things to say as well. Sure.
Yeah, what I wanted to say is that I think part of the issue, and I think that case illustrated it so clearly, is that the inpatient program, the goal is rapid discharge. And so their goals are and they're valuable goals, but the issue of longer term treatment and what those interactions are going to mean in the longer term may not come up. And I think the question that always seems awkward to me is how to present a case for changing a medication regimen that's been prescribed by someone else. In other words, the patient's just come out of the hospital with this bevy of treatments, and now you're wanting to make changes to it. And I think the way you suggest doing it, Kesh, is a good one, which is, again, this is the point at which shared decision-making and a strategy become important in terms of what should be discontinued, how should dose be changed, and what should the strategy be going forward, because it is indeed a challenge.
Now, what I would add to that is, which is not often happening in practice, is a strong communication between the inpatient service that is discharging the patient and the outpatient service that is accepting the patient. Very rarely do recommendations go. Now, the patient is on 30, but you would want to consider bringing it down closer to 15. Patient is on 3 antipsychotics, you may want to consider simplifying the regime. Maybe you may want to consider an injectable or things like that. So, yeah.
Yeah, and I'm seeing a couple other similar points in the chat about PAC standards, what people have been doing in their practice. So that's very helpful.
Yep.
Another question in here, Dr. Keshavan, can you speak on dopamine receptor hypersensitivity psychosis, how it presents clinically in early psychosis patients, and any differences from multi-episode patients, and any treatment strategies associated with that?
Yeah, so dopamine supersensitivity psychosis is a somewhat debated concept. So the idea is that if you are treating someone with a dopamine blocking agent, we are basically denervating those dopaminergic neurons. And when you suddenly stop the medicine, the hungry dopamine receptors become overactive because now they're not being blocked anymore by the antipsychotic. And so the dopamine flow that has increased in response to that blockade now has a free flow. It's like a dam being broken and the flooding happening of dopamine. And that causes a psychosis, which often is difficult to treat. And so this has been described in a number of different scenarios, including after stopping clozapine as well. The dopamine supersensitivity syndrome is often seen after stopping clozapine. Sometimes the relapse that happens after clozapine stoppage can be difficult to treat. But there, it is not just a dopamine supersensitivity, but another phenomenon that happens called cholinergic rebound, because clozapine is an anticholinergic drug, and when you take it away, it flows a heavy dose of acetylcholine in the system as well. It can produce a lot of symptoms related to that. So the treatment of dopamine supersensitivity syndrome is back to treating them with a dopamine blocker. So and often you may have to use higher doses than originally. So
I was going to comment. I think the original idea of a dopamine supersensitivity psychosis came about almost as in response to the fact that tardive dyskinesia, an late occurring extrapyramidal symptom of syndrome of abnormal movements, is usually first seen when antipsychotics, dopamine D2 antipsychotics are stopped.
Yes.
And the question was, so this is an extrapyramidal effect. Is something similar seen in terms of other kinds of phenomena that are blocked, that are treated by blocking dopamine receptors? And I think, as Kesh has said, it's not widely considered to be a there's a lot of debate about whether dopamine supersensitivity psychosis exists, although little debate, in fact, I would say none, about the fact that tardive dyskinesia exists, much more so with the older first generation antipsychotics like haloperidol, fluphenazine, and chlorpromazine, but even, although to a lesser degree, with the newer medications that we have.
Yeah, no, thank you. Those are very helpful thoughts. As a clinician, I've seen some of this and I wondered, there are two kinds of relapses that happen in people with schizophrenia when the medicines are discontinued. One is an immediate relapse. The moment they miss two medicines, two doses, and they begin to have psychotic symptoms, that could be dopamine supersensitivity related. Whereas true relapse of the primary illness takes a couple of months.
Right.
That is the more common thing. And
Right.
when patients stop taking their medicines, they next visit, they come and say, I'm feeling great. It's like a honeymoon phase. And then, within 2 or 3 months, they're back in the hospital. That is a relapse of the primary illness. So one needs to make that kind of a distinction between the immediate relapse and something that brews over a few weeks.
Yeah, I would like to add that there are antipsychotics in development now which target dopamine without blocking postsynaptic D2 receptors.
Yep.
For example, KarXT affects muscarinic acetylcholine receptors, and in the striatum, acetylcholine prompts dopamine release. And that's passed a phase 3 trial with better results than expected, including negative symptoms.
That's an excellent, Charles. So you're absolutely right. A newer drug, which KarXT, just for people who are not familiar with that, it's also called xanomeline, which works by acting on the cholinergic system. But it also has a secondarily some effect on dopamine. It works on reducing dopamine release or synthesis. So it doesn't cause the problem of a postsynaptic receptor denervation or blockade. So that from that sense, it may be actually in some ways better. We don't know. It's not even approved by FDA yet, but
Right.
it will be. I'm sure Nina will say more about these new medicines as we get into that. But there is
About
another.
how long?
Sorry?
About how long will it be before that's available?
Maybe a few months. Nina will say more.
I think they're talking about submission to the FDA before the end of the year, which means that it would probably be available sometime in 2023. The drug company is, of course, very, very excited.
Yeah. And there's another class of medicines called TAR1 agents. This stands for triamine receptors agonists. So they also work, by a different mechanism than dopamine, even though they have an effect on dopamine as well. So there is some excitement in the field for that group of medicines as well.
Right. And those are currently in, I think, phase 3.
Yeah.
Phase 3 trials, which is sort of the last phase before the drug is submitted to the Food and Drug Administration for approval. So there are things on the horizon.
I can follow up very quickly on this question. That was actually me who asked about dopamine receptor hypersensitivity. Hi, Cash, and hi. I am Elena Ivleva. I am at Dallas UT Southwestern Medical Center, director of the early psychosis program, and I also work in the BSNP study with Dr. Cashman. So I think what I had in mind more, in addition to the scenarios which you described, which is discontinuation as well as TD, I think, what I encounter quite a bit in my early psychosis patients is where they kind of, fail one antipsychotic after another. And this is in a scenario of adequate trial in terms of both duration and dose, and, trying to be reasonable and start with, dopamine sparing agents like Abilify and brexpiprazole, and then progress to risperidone, and then progress to long-acting injectables, and then to olanzapine. But there is a proportion of patients where there seems to be this kind of like treatment refractory pattern, which happens from get-go. And I think in early psychosis population, it's something like 12 to 15 to 20% of patients who start showing this pattern. So I've also read this, that dopamine receptor hypersensitivity mechanisms plays a role in basically the scenario where the previous antipsychotic in a previous dose worked perfectly for say 6 months, and now it's just not working. And that happens quite a bit, and it happens with long-acting injectables, etc. I just kind of wanted probably your thoughts on, what's the best strategy to manage these patients, given that, the idea of head-to-head comparisons of antipsychotics, they're equivalently, efficacious. Do you use any particular kind of progression of antipsychotics, first, second, third, and that kind of thing? Thank you so much.
Yeah, no, thank you, Elena. And, you really asked the question that leads to what I was going to bring up, and that is clozapine. And there is this one medication which is often relegated to multi-episode chronic individuals. But more and more, the field is beginning to think about introducing them earlier itself in the course of a schizophrenic illness. If two antipsychotics with adequate dose and duration have not been effective, it is worth considering clozapine early itself, even within the first couple of years of the illness. And if clozapine is not applicable, or the patient is unwilling, or there are other challenges, one could consider alternative approaches like supplementation with a mood stabilizer in some situations, using lithium as in combination, or Lamictal, lamotrigine, valproate. Those are, again, there's not a strong evidence that this kind of a combination is truly any more effective, but it's definitely worth trying in some individuals. And if you're going with a third antipsychotic, and if it is not clozapine, make sure that it is a different mechanism. So if you have used a dopamine blocker first, and then a dopamine serotonin agent that didn't work, go with a partial agonist and see if it works.
Right. I think one of the other issues to consider is that when we think about psychosis, first episode psychosis, and then as we're narrowing toward even those diagnoses like schizophrenia are enormously heterogeneous. And it may well be that there are some people who show the phenomenologic pattern that has us absolutely convinced, and with good certainty and good care, that the diagnosis is schizophrenia, but that this is a condition that is actually caused by some different underlying mechanism. And in that case, the medications that we have available really may not work. It's probably a very small proportion of patients, but I think one of the things that we're seeing with these newer agents is an attempt to get to medications that work through different pathways to achieve symptom resolution of the same phenomenology that we're all very well familiar with, but using a different pathway. And that may be, important in the future. But I cannot tell you how eagerly I am awaiting these medicines. But I've been eagerly awaiting new medications that are different for a long time.
Yeah. Well, it is encouraging as well as sobering, you saying that.
Absolutely, a combination of both.
Yeah, but the point you bring up on heterogeneity is so critically important, and I have two things to say about that. First of all, clinical measures do not help us in knowing who will or will not respond to treatment down the road, or will not have a good outcome generally, and so on. So there is a lot of thinking in our own group and others. Elena is part of our BSNF consortium, and where we are hoping to identify biologically meaningful subgroups among psychotic disorders that may have different courses and outcomes. We just got funded a study to follow up first episode psychosis patients longitudinally with a baseline biomarker profiling. And our prediction is that one particular subgroup, which we call biotype 3, may have a somewhat more benign course down the road. And these may be the individuals where after a year or two, one could consider a dosage reduction, perhaps, maybe even dose discontinuation. And there is another subgroup, which we call biotype 1, where the neural signature in our thinking might actually predict a therapeutic response to clozapine. So that's another study that is ongoing this time from our group. So those are two things. But clinically, we still can make some, good judgments. For example, if someone's psychosis clearly is explainable as induced by cannabis, or is something related to an ongoing psychosocial stressor, we should be careful not to commit such an individual to long-term antipsychotic treatment and revisit or reevaluate in a year or two. So this is where early and comprehensive assessment becomes so critically important.
Thank you, Cash and everyone. That's really interesting.
I would like to give Nina a few minutes to give us an overall big picture summary of where we are going.
Right. Well, thank you. This has just been wonderful, marvelous interactions and conversation, and I hope it's been as rewarding to the rest of the audience as it has been for me. There are just a couple of points. I'd had a couple of points that were on my sort of bucket list of what I wanted to make sure had been touched upon. And what's been wonderful is that virtually all of them have been. One is the issue of identifying poor treatment response early enough and starting clozapine relatively early. Once there's documented non-response to 2 antipsychotics at adequate dose and for adequate length of time. And so that was one, and I'm really thrilled to hear how that's been emphasized. The second has been the importance of teams and indeed the coordinated specialty care models that have been developed over the last 10, 15 years in the United States, and even longer throughout the rest of the world, and how valuable those are for understanding not only how medications can be used, but also all of the other treatments. And of course, that's not something we've talked about today. But there's one issue that's come up only briefly, and I want to take the last 2 minutes to highlight that. And that's the role of long-acting injectable antipsychotics. And one thing that we're very, very clear about, if we've been able to document non-adherence, poor alliance with medication, or non-compliance, which is what we used to call it in the old days, when we were telling people what to do rather than asking them about what to do. What we've learned recently is that long-acting injectable antipsychotics probably shouldn't be reserved only for people who've demonstrated to us unequivocally that they're not taking their medications. They really can have an important role even earlier in the course of first episode, early course treatment. And what I'm referring to here are two recent studies that have been conducted. One was a multi-center trial called Prelapse that was led by John Kane and that I was fortunate enough to be part of, in which we administered either long-acting antipsychotic, in this case aripiprazole, or treatment as usual, which was anything that the prescribers chose, the prescriber and the clinician and the individual chose together, which could have been a long-acting injectable. And we showed a reduced risk of hospitalization over the succeeding 2 years. And it was a very dramatic difference. So why should this be the case that we see this even in people where we do not have a documented history of non-adherence? And I think what it is that particularly early in the course of illness, there are other advantages that a long-acting antipsychotic can provide. And one of the very, very valuable ones of those is actually convenience. So that if what one needs to do is take a medication once every month, that's really a lot more efficient than having to take medication daily. And the other advantage that a long-acting antipsychotic provides is that you may remember the interesting list that Kesh showed. It had about 12 items on it, if I remember correctly, of reasons for non-adherence. And they were very, very varied, very varied indeed. But if someone's non-adherent to an oral medication, we may not recognize that until either they become symptomatic again, or come back and actually end up in an ER. Whereas if someone's taking a long-acting injectable, the minute that person doesn't show up to get the injection, literally within minutes, we know that that person is at risk not to having the protection of the antipsychotic medication, and we can intervene. For example, somebody can make a telephone call. Did you forget to come in? Have you decided you don't like this medicine anymore? And we're ready to respond. So it's a communication thing which can improve shared decision-making. Now, many people, when first offered the opportunity for long-acting injectable medication, the first response anybody has, almost anybody, is, I don't like injections. And I would love to see a show of hands of people who do like injections. And that's a place for shared decision-making, because I can always say, neither do I, because I don't like injections either. And that makes it possible to discuss the possibility of what this treatment might do. But the point is that the first thing to offer is not an injection, but the possibility of only needing to take this medicine once every month. And then it turns out the way we administer it is with an injection. So that's a particularly long, maybe sales pitch, if you will, for the advantage of these kinds of drugs, medications early in treatment. And I would love to come back some future time, because in particular, I would really love to hear both Charles and Nate's response to the ideas of a long-acting injection. And I'll stop there.
Yeah, briefly, my response is, I agree with everything Nina just said, but I would add that here in Watertown, Mass, there's a local biotech company named Lindra Therapeutics, And they're working on long-acting pills for antipsychotics. Currently, they have once a week risperidone orally, and it's been through a phase 2, and they're working on once a week aripiprazole. But the hope is they can get up to once a week or once a month even. Their platform can work for once a month pill. Then you don't have to have that discussion about not liking injectables.
Thank you.
I don't know. I guess I urge some caution with the long-acting injectables because, I mean, they may treat the symptoms for a longer amount of time, but another thing that they also have is inducing side effects. It might be more convenient, but it might also be longer. So, I don't know. I'd approach using those cautiously.
Right. Generally, you want to know what the person's response in terms of side effects to that medication is orally before you'd administer it in a long-acting injection. So it's the same medication, and if someone has a okay response, you wouldn't use something that person had side effects with. So you would have made that would be determined before using the oral medication. And that's a good point. I should have mentioned that. You want to know that it's not a medicine that will cause side effects for that person. Thank you.
Great. Well, thank you so much, everyone. I will bring attention. Lola put a link to the post-event survey in the chat here. Will we also be sending up a follow-up email, Lola?
Yes, you will be receiving a follow-up later today. Please fill out the survey. If you have the time, it helps us keep our funding, and feel free to visit the MHTTC website for future events.
Great. But yes, thank you so much. This has been really interesting.
By the way, this will be recorded and will be available to everybody.
Right.
Yes.
We'll send out a link as well to this.
Right.
Thanks, everyone. Thank you, Nina. And
also,
you.
Thank you.
Thank you so much for including me. I really enjoyed participating.
It's our pleasure.